Hey, we're still going strong. Our final speaker is Dr. Stephen Intille. Dr. Intille is an associate professor in the College of Computer and Information Science and Bouvet College of Health Sciences at Northeastern. His focus is on the development of novel healthcare technologies that incorporate ideas from ubiquitous computing, user interface design, pattern recognition, behavioral science, and preventive medicines. Area of special interest include technologies for measuring and motivating health-related behaviors, technologies that support healthy aging and well-being in the home setting, and mobile technologies that permit longitudinal measurement of health behaviors for research, which we've all been waiting to hear about. So welcome.
All right, well, I'm pleased to be here today. Occasionally I go to meetings and I feel like a fish out of water because my background is in engineering, and then I kind of moved into the health space. And here, though, I feel a bit like a fish out of water because the problems that you're interested in and the things that I do are a little bit different. And then I'm interested in measuring a lot of detail at the individual level. And so when I was asked to do this, I thought, okay, that's what they want to hear about. But your request was actually what technology is being used and what is possible to gather data on the BMI prevalence and trends of obesity in children, and what could be used to understand the variability. And that's a little bit different than what I normally do and think about. So this is me with a little bit more hair, I think, stressing out about what to say here, because actually this is a challenge for me to think about how technology could help with your particular problem. So one of my messages is maybe it's time to start thinking more broadly about intensive longitudinal measures, and that's different than what you're looking at here. But I hope you go away with that. So I'll start with some just crazy ideas of me brainstorming and asking a few colleagues also if they had any ideas, and their comments, some in exercise science and other fields, and their comments basically ranged from what's wrong with NHANES to why are we using BMI at all? It's a horrible measure. So I got all sorts of responses, and then at the end I'll just talk a little bit about what I mostly think about, which is measuring things in a different way. So I know that I missed the early talks, but I know that the challenges here are in measurement error for particularly something like BMI. And this was on my wall. My wife measures my daughter's height, and the other day we needed to know the height, and I remeasured it. And what we discovered was that on 614, she measured it my wife measured this high mark, and then I measured my daughter, and I discovered she had shrunk in a month. And so we were laughing about this because she couldn't figure out how in the world she had made such a large measurement error. And she's a well-educated individual, and so there's a case of that. And then we know with scales, I worked on a weight loss study with mobile phones, and we gave people Bluetooth scales, and you tell them don't put them on carpet and things like that, and they do it anyway. And so even giving somebody a scale, and you think that would be a relatively simple thing to do, you can have measurement error there too. So the disclaimer here is when I'm thinking about ideas about how to get a measure of obesity, and I know BMI, there are alternatives to BMI, but the disclaimer is that most of the ideas I can think of may not do much better than what you have now, say NHANES or BRFSS, which I know is for adults, and then others for children, the self-report for children. You really want EHR integration and data sharing, which is what was just discussed, right? And most of the ideas I can think of require either policy changes, substantial resources, buy-in from some sort of technology giant like Google, or intensive coordination among researchers. And so I think they're all actually quite tricky. Again, at the end, I think where the big opportunities are in intensive longitudinal data, then I think there are lots of opportunities. So I'm going to go through a couple random ideas I came up with that are hopefully just get you thinking a little bit. And these may not be good ideas, but I was having to stretch to think how can technology and mobile technologies help with measuring sort of at this population level. So one is partner with scale makers, the people putting out some of these devices, and figure out how you get buy-in, deal with sampling bias, the cost issue, the measurement error, the reaching out to people, getting the populations you want, and then things like wireless contracts. So you really don't want, for example, the Bluetooth scales that communicate with phones. You really want the ones that have an actual sort of phone in them, and they just send off the weight measurements, and so there's more reliability there. But this is a challenging way to go, pretty problematic. But you could say, look, if people are selling millions of scales, maybe it's possible to tap into some of their data. You could think about doing regular self-report via phones. And so I know that there's a skepticism about self-report, but if I get an app on your phone, it changes things. Because one measurement where my wife made the error, right, is an error. But then I made the error not long after that, and we discovered the error. So if you ask people to do a repeated measure, you're going to be able to get rid of some of the noise. So you can imagine an app that sits on the background in people's phones. It auto-detects things like their location, when good measurements may be possible to take, like at the school or at a gym or when they're at home with a scale. And then it may prompt for measurements very infrequently. So basically it does almost nothing, but every once in a while, every year or so, it just asks you to take a new measurement. And if it doesn't trust it for some reason, it might ask you to take it again later. And so you sort of get rid of the noise by asking for multiple measurements. And that may be a possibility if you can incentivize people in some way to facilitate engagement with that app. So you could also think about things like, if you've heard of Text for Baby, it's something to help expectant mothers and their families by giving them information that's very tailored and customized to them, and they do it through text messaging. And you could imagine something along the same lines for just getting people's weight and height measurements, so you could estimate BMI. And it could be similar to the phone app, except in this case you don't even need the app to run on the phone, which would actually make it simpler and probably more robust in some way. Again, you'd have to incentivize to facilitate the engagement. You can think about things like crowdsourcing, and crowdsourcing within the engineering community is a hot topic these days, because if you do it right, you can actually get people to solve very complex problems. And so taking a measurement is actually a relatively simple problem compared to things that people in engineering are able to get people to do via crowdsourcing. So you can imagine web apps that don't just ask somebody like the child or the parent to enter weight, but rather they're incentivizing children to get measurements of their friends, or children to get measurements of their parents, or vice versa, the parents to get measurements of the kids, but to do it in a really clever way where they're quite incentivized to do that in a more, almost like a game-like fashion, and then it sends that data off to a national repository in some way. So here again, you have challenges of incentivizing people to do this, but part of the way you can do that is by trying to make it engaging and sort of a fun experience. You have issues about unique IDs. With many of these ideas, you have this where, how do I know that if the kid was running this app and then stopped for a year and then starts running the app again, how do I connect them back up again? And then reach, how do I actually get this app out there in the first place? But it is possible to design very rapidly scaling sort of effective apps if they kind of catch on in the right way. And if you get a big organization like the NIH or personalities like Oprah Winfrey or things like that, you get people to promote these things. Sometimes you get amazing uptake in very short amount of time. So you could also think about crowdsourcing to create community health workers, essentially, right, where you do things where you take software like people management software, the types of stuff that Obama used in his campaign, where it's helping individuals coordinate how to go out into the community and get something done. In their case, it was get to the polls, right? But here it could be get accurate measurements. And so I think thinking beyond an expert in a clinic, which is relatively expensive and difficult, thinking about a community health worker in the US who's really your neighbor going around and actually trying to get better measurements. It might sound a little crazy, but I think it's possibly doable. And especially as we heard about the problem between the national level and the community level, at the community level, this might make a lot of sense. And the technology could really facilitate that. The reason that they are able to do that in elections today is because the technology will support this amazing kind of on-the-ground infrastructure. You could imagine using the same thing here. So you need infrastructure, publicity, and incentives. Whoops. A different strategy would be, again, this is sort of at the local level, are things like kiosks. So where you put a kiosk somewhere where there are a lot of people, and basically as people pass by, you use computer vision, and then you estimate their height and to some extent their size, right? Now this is going to be a really noisy measurement, but if you stick it somewhere where there's lots of people, eventually you're going to get some sense of what is this place like versus some other place. And you could try to characterize the noise in the measurement things like that. So this would be relatively expensive to create and maintain, highly localized and somewhat of a noisy measure, but still I was trying to think out of the box of what could you do with technology. You could also try crowdsourcing with pediatricians. And so rather than relying on these little local pediatricians who don't have an EHR, or trying to rely on the people who have EHRs that don't connect to any other EHRs, instead you try to crowdsource and incentivize the pediatrician. So you might create a mobile app that's for families, and when they go into the pediatrician's office, they're in the waiting room. That's a great suggestion, actually, in that dead time. They're in the waiting room, and they're incentivized to tell their pediatrician that they want to report the values. And so technology, it's really hard to do this type of stuff without technology, but with cleverly designed, it's not easy, but cleverly designed technology, it might be possible to get something off the ground along these lines. So EHRs were just obviously talked about and would be enormously valuable, especially if they actually all talk to each other like we dream they will someday. One thing that could be done there is something for the EHRs that's similar to the blue button, which is designed for consumers, but a blue button for the EHR or for the pediatrician to basically make it easier for them to export out of there. And it might be something that the patient has to be involved with in some way. Going back to crowdsourcing, you can imagine crowdsourcing to get the schools involved. So again, here, I think a lot of this stuff is about incentivizing. And if you create an incentive for the school's nurse and for the child in some way, you can think about there are ways that the technology might then facilitate actually making the data transfer happen if you have the appropriate incentives. And this, again, is the type of thing that technology can do. If you think about flash mobs and stuff like that, they're ideas that sort of sound crazy, but then they actually work to a certain extent. And along these lines, I think if we thought creatively about how to incentivize the schools, you could potentially get around some of the bureaucracy that currently hinders some of the efforts. Leveraging the fitness app data that's on a lot of the mobile phones would make a lot of sense. So here you could get tons of data, potentially millions and millions of people relatively rapidly. However, you're going to get very noisy data, but you're going to have lots of it. And so then the challenge basically becomes cleaning up that data. But in order to do this, you'd really need to get industry buy-in from the organizations making these apps, which is not there are a lot of app companies, but the ones that are sort of by default installed on everybody's phone or now smartwatches are relatively small number of companies. So if there's a coordinated effort in going to talk to them, that might not be out of the realm of possibility. And then you have Apple's recent Toolkit for researchers, which is another way to get the data. So this is designed to be able to get whatever data people are entering into their phone and to share it for research purposes. It's so similar to, say, Google Fit, but in this case, they've actually released this way for researchers to grab the data already. And again, the problem here is that it might be easier to get this than from the fitness apps that aren't research tools, but you have kind of similar challenges in that you probably need to partner with Apple to get exactly the data that you want. If you're not familiar with the Precision Medicine Initiative, that's something the committee probably wants to look into. In fact, there's a meeting yesterday and today out on the West Coast, one of several meetings where the working group is trying to figure out how to implement President Obama's goal of having precision medicine, which Francis Collins, the head of the NIH, would like to see a 1 million-person cohort in. And they're talking about using mobile technologies for that. And so the discussion there is, how do we get 1 million people? If we have 1 million people, how can we use their mobile phones and other devices to gather data off them? And these will be very imperfect data sources, but in some ways similar to what was just discussed. If you have more data, sometimes you can clean things up. And this would be intensive longitudinal data, possibly, on a subset of those 1 million people. And so that may help in terms of measuring obesity and change over time. You can imagine things where, again, you partner with a company. Imagine that Google, you got them to agree to a single-day blitz where they put this little note on the bottom. It says, enter your child's weight and height, win $4 million, okay? I guarantee you will get, in a single day, you will get millions of people signing up. And then you can think, well, okay, it's self-report. How do I know it's any good? Well, you know, simple strategies might actually solve the problem. You say, if your height and weight are in there and they're not accurate and you win the $1 million, you won't win the $1 million, right? Already your quality of your data has gone up. And then you ask them that, and then a couple weeks later, you prompt them again and say, in order to win the $1 million, you have to enter your info, and it has to be essentially the same information as it was before. Otherwise, your data is sort of suspect. And so things like that aren't going to get you perfect, you know, samples and all that stuff. You obviously have a lot of bias, but on the other hand, it may open up the doors to get apps on people's devices, on their browser and their phone, and that might allow you to gather a lot of other types of information. And then finally, there's instrumentation. So you can think about perhaps putting devices in people's homes. A lot of engineering folks are trying to figure out ways to do this. And you could instrument the bed with weight sensors, for example, homes with height sensors. So you could automatically know sort of what somebody's height is, toilets with weight sensors, entry areas on the floor with weight sensors. So people have done a variety of these types of things. They're all, I would say, very expensive and therefore not practical at any scale. But people are out there doing them. So if you wanted to instrument a small number of people at a much higher level, which for just finding out whether or not they're overweight or obese doesn't make any sense because that changes so slowly. But for other problems, people are interested in studying these sorts of things. The bed sensors, for example, for studying aging in place and whether or not people are having sleep problems and having problems getting out of bed and things like that. People are doing stuff along those lines. And you could also talk about embedded assessment where, let's say you get video game providers to just embed within their programs bits of information that you're interested in acquiring. So when you play many racing games, for example, the first thing you do these days is you customize your avatar and you indicate what they are. And it's not beyond the realm of possibility that one of those customizations could be asking for what measurements, and devices like the Kinect, for example, could even verify that a height measurement was not completely ridiculous. It wouldn't really be able to do anything about weight, but at least with height it could verify that something wasn't just a crazy range. So like I said, these are crazy ideas. So I was having to think pretty hard to try to figure out how technology could help in your case. So there are simple, sort of, I'll put it in quotes, alternatives to BMI. And there's a possibility that waist circumference or waist to hip ratio, that special devices could be made that might make the measurement of that a little bit better. Even apps on the phone that you would use to sort of rotate around your body might be able to help in some manner. So these are things I haven't seen people really thinking about, but it's not beyond the realm of possibility that one way to make these better measures is to make them just easier to measure, and maybe there could be something more like a blood pressure cuff, but it's more of a waist circumference cuff, right? And it just does a reliable measurement and you don't have to work so hard at it. Same for bioelectric impedance. Okay, so those are my ideas, and then you can burst the bubble of, you could say those are all totally crazy, but that's basically the best I could come up with thinking about just overweight and obesity and measuring it over time. The challenge is that you don't need really common measures, and so, or you don't need intensive longitudinal measures, and so you don't want to spend a lot of resources trying to measure something that you're hardly ever going to need to measure. Where I think the most interesting stuff is in what I would call small data in the long run. This is the type of data that we don't collect at all, for the most part, or haven't. And so we hear a lot about big data, which is really, I'd classify, most people think of as the hospital type of data that we just saw, the EHR. But what some in engineering would call small data are where mobile devices play a big role. And so the big opportunity, I think, here is that today, if you're going to measure something, it's often surveys with behavioral snapshots. You have limited information about the context, limited information about dynamics. It's costly to recruit people, often limited information about the why of the decision making. And so all throughout today, this is basically what you heard is the limitations that we're dealing with. I think soon you're going to have open source phone apps with sort of optional add-on sensors, months of continuous data, citizen scientists who donate information, and then getting some context or purpose information about what people are doing. And what that's going to let us do is, in addition to the hypothesis-driven investigations to understand correlations that we do now, you're going to see added on to that more data-driven, incremental, and kind of interactive discovery. And that can support not only new science, but also intervention design. So I already know that, as we all do, right, that we have an overweight and obesity problem in the country. And so while I think it's great to measure it with more and more accuracy and precision, I also think that we don't need to wait to start trying to deal with the problem. And if you're dealing with the problem, if you're a designer, you measure different things than a scientist who's interested in health outcomes. And I would just encourage the committee, even though it's not your charge, to perhaps point out that if I'm designing a solution to a problem, I need a different set of data. And so just arguing that we need more and more data to understand the minutia of the problem, and we know the problem's enormous, to me seems like we need to simultaneously think, how do we get the data we really need to develop the solutions that we need? So the conversation earlier about the difference between the national measurement and the local measurement I found fascinating, because it just shows you that they're struggling. In fact, the national measurement, it sounds like in some sense, hurts their efforts to try to develop local solutions, which is the exact opposite of what you would like it to be able to do. So I think it's worth it to think about how you do these things, and the opportunities are very different. So if you think about big kind of medical data or the EHR data from the last talk, you have hospital data sets from people's visits, and they're lucky in that case because they have child visits, but for adults, you don't have that almost at all. So it's tougher for adults, actually. But the data is relatively homogeneous in some sense. You've got experts sort of in control of it, but relatively few data points from relatively large numbers of people. It's generally temporally sparse, although again, the data on the children is better. And you've got these population models that are more useful, I'd say, for medicine than wellness. And the more healthy you are, typically the less data there is and the less interesting it is. And then it's controlled by hospitals and medical providers. They have trouble interacting with each other. And then the data sets sort of, though, exist, which is how we have the prior talk. But if you look on your right-hand side here, this small, big data, I think, is where the real excitement's going to be in the future, because you're going to have really intense data on what specific individuals do over long periods of time. And if I want to design an intervention for you, especially a technology-enabled one, but if I want to design an intervention for you, then I need to know what is it you care about, what is it you do, and the more I know about that, the better intervention I can design, whether it's for a person who's doing it or for a computer implementing it. And so these sort of digital footprints of what people do, where you have huge numbers of data points from relatively small numbers of people, some of us think that's really going to change the way that we think about health research and health interventions, where you have a computer that's building up an individual level model of a person, and then either a human interventionist or a computer program is then using that model to try to figure out what they do. So I think the caveat here is that these are currently very small, so it's relatively small numbers of people, but the caveat is that's true until they're huge. So already it's very easy to find people wearing Fitbits and stuff like that. The data's sort of coming in. All your mobile phones are capable of tracking all sorts of things. We're talking about having a perhaps million-person volunteer cohort of people, a subset of whom might donate this sort of data. So I think in the next 10 years, you're going to see a real shift from having it be hard to do this to having it be truly viable doing this. And that's what I think I'll probably leave it at that. And there's lots of things about how people are doing this. My group's doing a lot of stuff on understanding the type, duration, intensity of physical activity, and things like that would allow us to build up these small, big data models. But I would encourage you to at least keep this in the back of your mind as you write your report. So that's I think I'll end there. And thank you.
Thank you.